Alcohol-associated liver disease is a part of a spectrum now, we believe, that's called steatotic liver diseases. So the distinction between these three categories are based on, number one, having at least one cardiometabolic risk, and number two, the amount of alcohol that one actually consumes, where you can go from one category to another category based on amount of alcohol you would consume. When you correct for alcohol underreporting, the prevalence of ALD and met-ALD doubles. The prevalence of alcohol-associated liver disease in the United States goes from something around 1 to 2% to almost 4.5 to 5%. Another message from this study is that having diabetes and binge drinking is really a double whammy, and it can cause significant harm to the liver and cause mortality. At the global level, I think we have an opportunity to understand that MASLD, ALD, and met-ALD are very important non-communicable diseases that the World Health Organization should recognize.
Alcohol is well known to be among the biggest causes and contributors to liver disease, but there's still more to be found out. So I'm delighted to speak to Professor Zobair Younossi, who is Professor of Medicine and Chairman of the Global Center for Liver Outcomes and Policy Research at Georgetown University, Washington, D.C., among many other prominent roles in the field. Welcome, Professor.
Thank you very much.
Could you start us off by giving us some of the headline findings from your recent Lancet paper, which gives new insights into the links between alcohol and liver disease in layman's terms?
Well, yeah, I mean, the alcohol-associated liver disease is a part of a spectrum now, we believe, that's called steatotic liver diseases. That spectrum really, with the new nomenclature in this context, is divided into three different categories. What we call metabolic dysfunction-associated steatotic liver disease, or MASLD. It used to be called NAFLD, or non-alcoholic fatty liver disease. And the other extreme, alcohol-associated liver disease. In the middle, a new category that's called met-ALD, where patients actually drink a moderate amount of alcohol and has metabolic abnormalities like diabetes, or they have central obesity. So the distinction between these three categories are based on, number one, having at least one cardiometabolic risk, and number two, the amount of alcohol that one actually consumes. So historically, we have thought about these three different entities as sort of silos, and there is increasing data from small studies that suggest that that this is really not a silo fixed sort of type of diseases, that there is a lot of overlap, and that the disease is actually more of a dynamic situation where you can go from one category to another category based on amount of alcohol you would consume. There were at the population level that has never been shown. So this study uses a use population data set called NHANES data set that had about 41,000 individuals, and we looked at these individuals over time. There were a couple of things that actually became very, very clear. One is that when you look at these categories of MASLD, met-ALD, or ALD, over about 20-year period of time, there is an increase in the prevalence of these diseases, almost doubling and sometimes even tripling the prevalence. So it's become more and more common. In fact, when you combine these diseases, the steatotic liver disease is the number one cause of cirrhosis, liver cancer, and indication for liver transplantation in the United States as well as in Europe. Now, of course, that includes both MASLD and ALD. So the first point is that there is an increase in the prevalence of all of these, of course, driven by an increase in the rate of obesity, type 2 diabetes, and probably more in some areas of the world, more alcohol consumption. The second thing that we actually found in this finding in this study, which is novel, is that when you correct for alcohol underreporting, the prevalence of ALD and met-ALD doubles. So historically, we've been dealing with this paradox where when you look at the most common cause of cirrhosis in our clinics. That's alcohol-associated liver disease. But when you look at the reports that came in from different parts of the world, the prevalence of alcohol-associated liver disease is actually 1 to 2%. So it's pretty small, but explaining a great deal of cirrhosis and liver transplantation. So this paradox had to be considered in a couple of ways. One, of course, alcohol-associated liver disease is probably more aggressive disease. But the second thing is that there has been a systematic underreporting of alcohol consumption. Probably not intentionally, individuals just don't record their alcohol consumption, or report their alcohol consumption accurately. So when we look at historical reporting of alcohol reporting by medical history, it's usually underreported. So in this study, we actually controlled for that underreporting in a population-based sort of study, and found that the prevalence of alcohol-associated liver disease in the United States goes from something around 1 to 2% to almost 4.5 to 5%. So that's actually a very important issue that may be part of the reason for the paradox that we're talking about. The second issue is that when you consume alcohol, then if you have other risks, then those risks can actually amplify the problem of causing more advanced liver disease. For example, if one actually drinks alcohol and has type 2 diabetes or visceral obesity, the risk of mortality from these diseases will actually increase. What we found in this study is that if you do binge drinking, and of course that's a situation where individuals drink quite a bit of alcohol, multiple drinks in a short period of time, that when you have diabetes and binge drink, the risk of mortality from alcohol-associated liver disease and meth-ALD actually is significantly higher. So at least another message from this study is that having diabetes and binge drinking is really a double whammy, and it can cause significant harm to the liver and cause mortality.
And in terms of what can be done about it, you mentioned in the paper some conclusions that you might make for public health and clinical interventions. Could you explain what they might be?
Well, I think there are a number of things that we can certainly do. First of all, we need to do a better job in terms of assessing sort of alcohol consumption, and this can be done in a couple of ways. One, it can be done by a very short questionnaire, which is called Audit C. So that's one questionnaire that can be done. And second, there is a blood test that's now available, and it's called phosphatidyl ethanol biomarker. It's called PET testing. It's a blood test that's available commercially. So if we discuss with patients that sometimes the amount of alcohol that's being actually consumed may not actually may not be considered as significant, but it may be. So doing a PET testing or an audit testing would be important. Second message is that we need to make sure that we manage cardiometabolic risk very aggressively in everyone that has MASLD, but also in those who have alcohol-associated liver disease, because 95% of patients with ALD or alcohol-associated liver disease will have at least one cardiometabolic risk, at least one. So the majority of them will have this, and the reason for this is that we need to educate folks about the synergistic harm of consuming alcohol, especially binge drinking, if one has type 2 diabetes. Those are really the three, at least important messages that I would like to sort of part with to the audience.
Yeah, binge drinking is something that pops up quite often in this field, and it's something that I think a lot of people would sort of think, well, that's just sort of normal, to binge, once a year or twice a year, but that actually does qualify as a significant risk, at least according to the study you've just completed.
The issue with binge drinking, that even if you go within muscle D, because muscle D patients or patients who currently don't drink significant amount of alcohol, some of them have a history of drinking and maybe even have binge drinking in the past. Even if they stopped, that harm of binge drinking never goes away. And that's the other message, that binge drinking is really not a good thing, even if you stop drinking. So, and especially in the context of type 2 diabetes.
Yeah, and I mean, maybe is maybe quite a technical question, but could you explain a little bit about how you adjusted for the underreporting?
There is actually a technique. It's a technique that's been used in other fields, but not in the liver field, that will allow you to adjust at the population level. So this, of course, is it depends on what type of data you have. This is a technique that will correct alcohol based on sex and frequency specific underreporting, and it's by an author called Stockwell, and then you calibrate that to the NIAAA, which is the National Institute of Alcohol in the United States, based on national per capita alcohol consumption data. So it is a bit of a formula that you have to use. It's a published formula. You can use that, and it may not actually get to everything. So I have to just make sure that the audience understands this, that even with this correction, we probably still are underestimating to some degree the true underreported alcohol. Because for that you need to have a more sensitive test like PET testing that I actually suggested. But you can't really do PET testing in a population-based studies of hundreds of thousands of patients that come in. So this was a simpler way. In a clinical setting, you don't need to really use this technique to correct for alcohol underreporting. You can correct it by doing PET testing. In fact, studies from Denmark has shown that if you take patients with muscle D and you do PET testing, say if you have a biobank or a blood bank that you're keeping for research, about 30% or 35% of patients can change their category from muscle D to either meth-ALD or ALD. In the United States, my feeling is that in most liver clinics or clinical trial patients, if you do PET testing, you probably change the category of MASH or muscle D to meth-ALD or ALD in about 10% of cases. So I think in clinical practice, it's much better to do either AUDIT-C or PET testing, and instead of actually adjusting in this way, which is a methodology sort of used for large data sets like Enhanced database.
And these results were drawn from US data sets. Is the same kind of underreporting likely to be the case in other country or regional data sets?
I think it certainly will vary from region to region. As I just suggested, in Denmark, the studies from Professor Krok suggested that a third of patients may change categories. But if you go to areas where alcohol is not available, either for cultural or religious reasons, then this will be much less of an issue. At least in the United States, with the studies I've seen so far, suggest around 10% or so is probably true. So I think it really will depend on which region of the world you're dealing with. I suspect in most regions of the world where alcohol is actually available, this is an issue. The numbers may change depending on sort of the cultural norms or the habits, but in general, I think this is an issue that could go somewhere between 5% to up to 40% in areas of the world where alcohol is available.
And I'm just guessing, but I suppose the cultural similarities between Europe and the US would probably suggest they're more likely to be similar than some other different regions.
Certainly, I think that the other difference is that I would also want to emphasize is that the prevalence of diabetes is high in the world, but it can vary. In some areas of the world, it's very, very high. So if in the countries where prevalence of diabetes is 15, 16, 20%, and alcohol is widely available, then this could become maybe even a major, even more of an important public health issue.
And just one final question. You've dealt with the situation within, the consulting room, within the medical setting. Are there things feeding into this situation which might help reduce the problem, in terms of policy or sort of environmental factors that might help reduce this problem?
Well, obviously, as clinicians, we really, deal with the tip of the iceberg. There are two major issues here. Of course, has to do with what we consume, both in terms of the food we consume with a lot of ultra processed food, and our and food that's not healthy. So I think that's the food supply can certainly be addressed at the policy level, and also consumption of alcohol. There is evidence that alcohol consumption, especially among adolescents, is increasing. And if you put these two things together, increasing rate of obesity in type 2 diabetes and increasing rate of alcohol at a young age, you have a double whammy that can ultimately result in a lot of sort of harm in the future from a liver standpoint. So from a policy specific side of thing, it'll be really important how to actually identify the true sort of drivers of both food consumption that leads to diabetes and obesity, and also pattern of alcohol consumption, and develop policies that will actually stop both of those at the national level, and then ultimately at the global level. At the global level, I think we have an opportunity to understand that MASLD, ALD, and meth-ALD are very important non-communicable diseases that the World Health Organization should recognize and move us towards a goal that not only we will eliminate communicable liver diseases like viral hepatitis, but also non-communicable liver diseases such as MASLD, ALD, and meth-ALD.
That's very kind of you to spare the time to explain what is a complex issue, and maybe somebody out there is listening who might act on some of the suggestions you're making there. So thank you very much for sparing the time.
Thanks a million for having me.